This is Crystal Fenn, MedPage Today. I'm speaking with Dr. Craig Della Valle from Rush University Medical Center about analyses of comparing gender implants for joint replacement. So, Dr. Della Valle, what is sort of the consensus in the field from this meeting on whether these gender-specific implants are really necessary?
Well, I think that as all the panel members, I think, agreed today that there are certainly anatomic differences between male and female patients. I think that's been long recognized. And I think that there are also certain clinical scenarios that we see more commonly in male or female patients. So the question is, can we design implants that will better fit patients over a whole wide range of sizes and shapes, and whether those better fits will translate into better clinical outcomes. So I think that all the panelists agree that there are differences and that we see certain clinical scenarios more commonly. The question is by changing the implants, are we going to be able to improve clinical outcomes, and what are the costs of those changes going to be?
So in these studies, they didn't find a real difference in outcomes for patients?
Well, in the two studies that were presented this morning, they really didn't find statistically significant differences with the instrument measures that were utilized. However, the question, being devil's advocate, would be, are the tools that they utilize sensitive enough to determine subtle differences between patient populations? For example, is giving someone a 1 to 10 scale and saying, how satisfied are you? Well, I'm satisfied a 9 out of a 10. Is that a good enough tool to detect subtle differences?
And so one of the questions also has been whether it's just a matter of getting the right size of implant rather than any subtle shape differences that's really making the difference, especially for many clinicians out there who are doing these procedures who may not be doing a lot of procedures every year.
Correct. And I think that you've hit the nail on the head there. I think it's a combination of both of those issues, size and shape. And the issues, again, particularly in the knee that we see, whether it now presently is a gender-specific implant, is that for certain patients, for a given height of their femur, which is very important to us in terms of how much bone we remove to create our gaps at the time of our knee replacement, which balance it out, that if you size it correctly top to bottom, that creates overhang medial-laterally. And the concern is that soft tissue rubbing against that metal that's overhanging could cause a clinical problem.
And so one of the other concerns at this meeting that's been voiced is whether there are industry relationships that are kind of confusing the matter. What are your thoughts on that?
You know, technically now 3 of the implant manufacturers say that they have a gender-specific implant. 3 of the 5 manufacturers. So I'm not really sure how to tease that out. I think the real concern is that, are we spending money that's unnecessary in terms of optimizing patient outcomes? Because I think as orthopedic surgeons, what we want is optimal outcomes, and are we spending the money in the right places to make those outcomes better? I'm not really sure if we know what the demographic of users and not users are, and what the relationships with industry are or aren't, to be honest with you.
So for you, when you're considering use of a gender-specific implant, what might make it worth the cost?
Well, you know, in my particular operating room, what we do is we always start with the standard implants, and I put my trial implants in, which are the same size and shape as what the final implants are going to look like. And then I bring the knee through a range of motion, I take a look at things, and at that point I make a decision. And I would say in my practice there's maybe 15 or 20% of female patients where I feel that there's substantial implant overhang, and then when I switch it out to the gender trial, that I feel that, at least to my eye, it looks better. And I'd say that also the same thing occurs in about 5% of my male patients. Again, the question in my mind is, am I making an emotional decision based on what I'm seeing, or am I making a scientific one based on data that says that by eliminating that overhang, you know, it's just one component of it, is that in fact going to improve clinical outcomes, or am I avoiding a patient who's going to have a problem? Because again, I think that's at least what I want to do, is I want to avoid a situation I can control by using an implant that fits better.
is the evidence there to support that getting rid of that overhang is really going to make a difference in outcome for patients?
Well, I don't know if we have all of that data. I would tell you subjectively that I think that the studies are mixed, as you've seen, and I think it depends on the instrument used to measure satisfaction and outcomes. But I think that there are a certain percentage of patients who are unhappy after the knee replacements where, we look at their x-rays and the components aren't loose, they don't have an infection, the knee's stable, but they're still not functioning well. So I'm not sure if we know 100% why some of these patients aren't doing as well. But again, intraoperatively, we see something that we can objectively look at and say, well, that doesn't look right. We can make it better with a different shape implant. So again, from my perspective, I think the whole idea of having other shapes and sizes is great in terms of it gives you more flexibility to try to do the best job that you can. It's just a matter of how much incremental cost, and if that incremental cost translates into better clinical outcomes.
Well, thank you, Dr. Della Valle. I'm Crystal Fenn, MedPage Today.